First of all, welcome back to my channel, guys. The first thing I would like to just mention is papilloedema is a very specific word that means that there is raised intracranial pressure. So that essentially means the pressure within your brain and spinal cord is elevated, and because of that, the nerves in the back of both of your eyes, or it can be one more than the other, the nerves appear swollen. This is an important distinction from disc edema, which is swelling of the disc, which is not associated with raised intracranial pressure. The other thing to clear up at this stage is the phrase pseudopapilloedema. So pseudopapilloedema refers to blurred optic nerve heads, which is not due to raised intracranial pressure, but can be due to other conditions, such as patients who are significantly long-sighted and therefore have crowded optic nerve heads. It can be because of optic disc drusen and also tilted discs. In terms of why the intracranial pressure may be raised, the actual intricacies of that are probably beyond the scope of this video. However, the simplistic way to think of it is within the brain and spinal cord, the structures are bathed by a fluid that is called cerebrospinal fluid, CSF. The amount of CSF that is produced needs to be equal to the amount of CSF that is leaving this circulation, if you like. So input must equal output. So if there is too much fluid being made, if there is too much fluid being removed, then there is an imbalance in this equation. Reasons why too much fluid may be being produced is because of things such as a papilloma. Reasons why fluid may not be being expelled as efficiently as it needs to be maybe due to a tumor, meningitis, etc. So the important take-home message at this stage is the fact that there needs to be a balance between how much fluid is coming in and how much fluid is being removed. In terms of diagnosing a papilloedema or otherwise, the key things to do include performing a history, which remember is the cornerstone to any consultation that ever takes place, and to ask about whether the patient is symptomatic. Have they been experiencing headaches? If they have, what type of headaches have they been experiencing? Where does their head hurt? How significant is the pain? Is it helped with analgesia? Is the pain worse and the headaches worse when they're lying down compared to sitting up? Is there associated nausea and vomiting? Do they have any other features as well, such as problems with their arms and legs, specifically in terms of the neurological system? Also ask about other symptoms such as tinnitus in their ears. Have they had a loss of consciousness? Do they have a fever? All of these things will help to try and guide you towards a possible underlying etiology. Before they even get into your consultation room, it's important to ensure that you have some of the basics performed, such as a blood pressure, a pulse, and a temperature. The blood pressure is important to check because a malignant hypertension can also cause swollen optic nerve heads, and it is something very simple that can be easily missed. Ultimately, as an eye care practitioner, the key things to perform when faced with a patient with a potential diagnosis of papilloedema, clinical tests that are important include a visual acuity, a visual field test, imaging of the optic disc, which is typically done with OCT nowadays, checking pupillary reactions, checking eye movements, and checking color vision. Once all of these have been performed, and if you reach a clinical diagnosis at this stage of a blurred optic nerve head, which can either be, as I said, unilateral initially but then become bilateral, is prompt onwards referral for the appropriate investigations, and this is typically done by the medical team or the neurological team, depending on the unit that you are based in. The key investigations that patients will need to have performed on them include a lumbar puncture and a CT scan. One of the common causes for papilloedema that we tend to see in ophthalmology clinics is benign intracranial hypertension or idiopathic intracranial hypertension. It's important to note that this diagnosis is actually a diagnosis of exclusion. This means that you have to go through a full list of potential diagnoses, rule them out before you can conclude that the patient has IIH. The diagnostic criteria for IIH are very specific, but in a nutshell, the patient should have papilloedema, should have elevated intracranial pressure, which is proven by performing a lumbar puncture, and in terms of their clinical anatomy on a CT scan, this should be otherwise pretty normal. The other thing to also touch upon here is that the clinical evaluation of a swollen optic nerve head in the context of papilloedema can be graded. The Frisson scale, which is on screen now, can help you to sub-categorize the grade of papilloedema. Once the patient has been adequately worked up and evaluated, depending on the underlying cause for the swollen optic nerve heads, they need to be managed appropriately by the correct team. If the diagnosis is that of a papilloedema due to idiopathic intracranial hypertension, then this will involve multiple teams, not limited to nutritionists, dietitians, neurologists and ophthalmologists for ongoing evaluation and monitoring of visual function. That brings me to the end of this video about papilloedema. Today I've introduced the concepts of what papilloedema is as opposed to just otherwise disc swelling. I've discussed key aspects of the history, how patients are evaluated, and what happens in terms of ongoing referral and management. So thank you so much for watching. If you've liked this video, give it a thumbs up. Please subscribe to the channel, click the bell icon. Until next time, thank you.